Hi, Siyabonga. Hi, Andile.
Hello, I'm fine. Thanks, and yourself?
I'm well, thank you.
Yes.
Would you like to test your slides?
Okay.
Good afternoon.
Hi there.
Hi.
Is that Gugu?
Yes, it's Google.
Okay, nice to meet you virtually. Just gonna
To
add
keep on changing the name.
Yeah, I was wondering who Yanda was.
Yeah, no, it's me. How are you?
Good, thanks. How are you?
Thank you.
There you go. It's looking good.
Yeah, can I stop? Or should I
And
go
do you want to
presenting more?
try it in presenter view just so you're comfortable? Yeah, perfect.
All right. Thank you.
Cool. And then Andile, would you like to go next?
Let me check. Let me check if she's already connected.
She's having a problem opening her slides. Are you able to open your slides, Andile? Or should I share on your behalf?
Otherwise, Gugu, if you'd like to test the intro slides.
Okay, sure. Let me just.
Hi.
Hi there, Andile.
Sorry, I was having an issue with my mic. Google, would you please share my slides for me? I'm unable to share.
No problem.
Thank you.
Are you able to see the intro slides?
Yeah.
Yes.
Okay,
Good.
no, that's fine. And then you're able to see the cases.
Yeah.
Yes.
All right, no, that's fine.
Thank you.
No problem.
So I'm going to play the intro video for now, and then at 4 o'clock, I'll turn it off and hand over to you, Gugu.
Sorry, you
Thank
what?
I'm going to play the deep dive intro video, which is just basically adverts for deep dive, and then at 4, I'll turn that off.
Okay, no problem. Okay. Afternoon, everybody. Please let me know if you can see the introduction screen or slide showing.
Afternoon, Gugu. Yeah, we can see.
Okay, great. Thanks, Estelle. Okay, I think we have enough participants that have joined the meeting. So I think we can begin. Good afternoon, everyone. I'm Dr. Gugu Jali. I am a clinical hematologist in KZN at Victoria Mklinga Hospital, previously known as King Edward, and I'll be chairing today's meeting. The topic that we'll be looking at or diving deep into today is confronting the aggressive cutaneous T-cell lymphomas. And we've got two of our doctors presenting, and I'll introduce them just a little bit later. So today's session is courtesy of UKZN in partnership with the South African Clinical Hematology Society and also the South African Stem Cell Transplant Society. We've got our deep dive management team who have been fantastic in coordinating these sessions and making sure that everything runs smoothly. We've got Prof. Verbag, we've got Gerdine, and also Nicole as part of the team. So some housekeeping notes. So these sessions are recorded, and these recordings can be found on the Blood Assay website under resources, and you can go under deep dive. Also, it is an interactive session, so please feel free to add any questions or comments in our chat box during the meeting, and we'll try and respond to all the questions at the end of the presentation. This meeting is also CPD accredited, so when you're registering, just make sure that all your information is correct, especially your HPSCSA number. And also you need to attend for at least 1 hour for you to get the CPD points. So to join the mailing list, you can find this under resources and you can subscribe on to Deep Dive, or you can use the QR code. Also, please feel free to give feedback to the blood assay and also to the speakers. It is quite valuable for us to see whether these talks are helpful or if you can improve on anything that's required. So you'll get the feedback survey at the end of the meeting. So today we've got two speakers. We've got a case presentation, which will be done by Dr. Andi Lenzimande, and then we'll get the presentation looking at the T-cell lymphomas, and this will be done by Dr. Siyabonga Votlega. And then we'll have a Q&A session, and then we'll close the meeting. So just to introduce our speakers, I'll introduce Dr. Andi Lenzimande. She's a medical doctor, was a medical officer currently at the Clinical Hematology Department in Albert Luthuli since 2024. She studied in Cuba under the Nelson Mandela Fidel Castro bursary and completed her studies at the University of Free State in 2020. She is an aspiring dermatologist who's also building her interest in hematology, and we are trying to change that interest. And in her private life, she enjoys gym and she's keen on learning daily. And then we'll also have Dr. Siyabonga Votlega. He's a qualified specialist hematopathologist, and he qualified in 2021. And then he joined the Clinical Hematology Fellow Program in Albert Luthuli, KZN, and that was in December 2023. He's passionate about sharing knowledge and provision of holistic care to patients with hematological disorders. And this is just a slide to remind everyone that we do have a deep dive session next week, and we'll be looking at the National Hemophilia Registry, and the information will be communicated with everyone in due time. So without wasting any time, I will be sharing Andile's slides as she's struggling to share from her side. Let me try and open it. Okay. Are you able to see the slides?
Yes, Google.
Okay, great. So Andile will be presenting. So Andile, you can go ahead. I will mute my side.
Thank you so much, Gugu. Good afternoon, colleagues. Can everyone hear me?
Yes, we can hear you.
Okay. So today I'll be presenting two very interesting cases. This falls under the topic of cutaneous T-cell lymphoproliferative disorders. Okay, you can move on to the next slide. So case one is a 44-year-old female referred to Victoria Mglenga Hospital Clinical Hematology in 2022. On medical history, patient was HIV negative and diagnosed with mycosis fungoides in 2015. She initially presented to dermatology at Nkosi and wasn't seen by hematology. She was treated with methotrexate, 10 milligrams weekly, and topical therapies. Upon staging and diagnostic workup, which was done in 2015, CT scan showed axillary and inguinal lymphadenopathies, and her left axillary node biopsy showed a dermatopathic lymphadenopathy, and her skin biopsy confirmed plaque stage mycosis fungoides. On staging, we staged it as a stage 2A, T2N1M0, and on clinical course, the patient then relocated to Zambia for work, continued her methotrexate until 2018 with no further treatments. And at that point, she reported no new lesions and there was clinical improvement. From the timeline of 2018 to 2022, so initially in 2020, patient had noticed intermittent waxing and weaning of the plaques and lesions. Then in March 2022, she started to have symptoms such as loss of appetite, loss of weight, unable to quantify, with skin shedding and plaques that were worsening, involving the entire body with associated pruritus. On further history, the drug history, patient was at that time on methotrexate orally, no radiation or intravenous chemotherapy. And on family history, there was no family history of any hematological malignancy, no transfusion history. On social history, she was living in Durban at the time with 3 siblings and with sober habits. Just on summary of her clinical findings, on general examination, our patient was clinically stable. There was no pallor, and she had lymphadenopathies in various sites. She had on the axillary, bilaterally on the inguinal region, and also the left anterior triangle. The largest node was on the axillary site, which was 4 by 3 centimeters. They were all mobile, non-tender, and firm. On general examination of the skin, patient had multiple tumors on the right face, upper arm, axilla, buttock, and thighs, and also had plaques, which were generalized over her face, torso, limbs, buttocks, palms, and soles. There were also sites of secondary infection, which were predominantly in the right axillary area and thigh, with oozing pus that was visible on those tumors. The rest of the systemic examination was insignificant. We can appreciate those tumors that are on her face and on her soles and palms. You can see the papules. If you can just move on to the next pictures, Gugu. And then there's also that skin shredding, which is on the soles of her feet. And also just on that right thigh, there's also tumors that you can visualize. At that stage, that was before we had any confirmation, our differentials was cutaneous T-cell lymphoma, mycosis fungoides, tumor stage with secondary infection of lesions or Sézary syndrome, or a possible transformation to a large cell lymphoma. The plan at that time was to do a FBC, differential count, smear, just to assess if there's possible Sézary syndrome, viral screen, biopsy, lymph and skin, if possible, a pus swab, staging CT, echo, and BMET with molecular and flow cytometry. The result of these investigations, our patient had anemia, HB was 9.8, with a high neutrophil count, neutrophilia, which was 6.9. And then there were no lymphocytes or lymphocytosis rather on smear. This ruled out Sézary syndrome. On skin biopsy, confirmed a tumor stage mycosis fungoides. And on bone marrow, there was no bone marrow involvement. Lymph biopsy was not done at this stage as the skin biopsy had already confirmed the tumor stage mycosis fungoides. And on her echo, she had an ejection fraction of 70%. CT staging also confirmed the mycosis fungoides in the right gluteum, bilateral inguinal axillary, and the extrailiac lymph nodes. And there were multiple cystic lesions, most likely benign. Diagnosis or confirmed diagnosis of our patient at this point was mycosis fungoides, which was between stage 3 to 4, classified under T4N1, M0, B0. Treatment and progress of our patient. There's just some time frames. We received this patient in October 2022. At that point, she received radiotherapy for 20 days, and chemotherapy was started with gemcitabine and isotretinoin. She had a good partial response. As we could see visibly, the lesions were reducing and clearing. In February 2023, she then developed new lesions. At that point, we restaged our patient with the PET, and the conclusion of that PET showed metabolic active disease in the lymph nodes above and below the diaphragm with soft tissue nodules. She was then commenced on oral methotrexate. And then in May 2023, our patient received radiotherapy. This is just the PET that's showing some nice illustrations. As you can see, it's illuminating on that right axillary and also the bilaterally on the inguinal regions. On progress, unfortunately, our patient demised. She relocated to Joburg, seeking a second opinion, and she received chemotherapy in Bara Hospital, and then she never returned for her review with us. We were later informed by the patient's husband that she had demised in 2024. In our second case is a 29-year-old African male referred to Ngozi Albert to dermatology clinic in 2022 with worsening, non-resolving pruritic skin lesions. On past medical history, he was diagnosed with anaplastic large B-cell lymphoma, which was diagnosed in 2018, completed 6 cycles of CHOP, and upon PETs in 2018, he was in complete remission. In 2019, he then developed a new skin lesion and was diagnosed with psoriasis and treated in private with methotrexate 10 milligrams weekly. Other relevant clinical history, patient was not known with any comorbidities, no surgical history, with sober habits and no known allergies. On clinical examination, we can appreciate scaly erythematous plaques, which were well demarcated and disseminated across the body, mainly the chest and the arms, with areas of crusting and oozing and bleeding. Patient also had purplish indurated plaques, which were noted on his face, with hyperpigmented patches observed on the palms of his hands with bilateral inguinal lymphadenopathies. On the left side, it was slightly bigger, which was 2x3, firm and non-mobile. And on the right inguinal region, it was 1x0.5 centimeters. There was no oral lesions visualized and no nail involvement. You can appreciate on especially his chest and his hands, those well demarcated plaques. He also had the pus that's oozing, we can see on his face, and then there's also some alopecia on his scalp. On FBC, significantly, there was no, or essentially there was no abnormalities. HB was 12. Everything else is normal. Smear, there's nothing of significant. On diff, there's nothing of significance rather. On smear, there was mild anacytosis, scanty large platelets, and pseudo plagiarism of the neutrophils. Biochemistry was also essentially normal, just the elevated LDH and ALP, but the rest of the LFTs were normal, and the viral screen was also negative. On bone marrow, there was no evidence of any lymphoproliferative disorder, and Trephine was also negative for any disorder. On flow cytometry, it was also negative for any bone marrow involvement. On skin histology, was revealed that there was a marked spongiosis and psoriasiform, regular hyperplasia and compact hyperkeratosis, CD3 predominance with CD4 predominance as well. And there was also a TCR gamma delta. These findings were in keeping with a primary cutaneous lymphoma with the expression of a TCR gamma and delta. Other investigations, chest x-ray was completely normal. There was no pathological findings. And his MUGA, the ejection fraction, was 61%. On final diagnosis with the histology, patient was diagnosed with the primary cutaneous gamma and delta T-cell lymphoma, stage 4A tumor, stage T4N2 M0. On immediate management, the plan was to treat sepsis for the patient and to co-manage with dermatology. And he received topicals, dressings, and was restarted on his oral methotrexate. Once the infection was controlled, patient was started on GDP, which was the chemo regime of choice. On progress, patient received 4 cycles of GDP, unfortunately defaulted due to work obligations and moving to Cape Town. He returned in October 2023, and we gave him cycle 5. Then once he completed 6 cycles, there was still residual skin diseases. So upon that decision, we decided the patient would be for palliation. And because there was visible disease, we did not repeat a PET for the patient. Can we go on to the next one? Unfortunately, due to the worsening of the lesions and new lesions, patient was then for palliation. Extensive counseling was done with the family and the patient, and we explained that the patient was for palliation due to the aggressive nature of the disease, and there were no further chemotherapy options. Thank you.
Okay, thank you, Andile, for that talk. Vox, are you able to share your slides? Let me stop sharing.
Okay, I will share now.
I stopped sharing on my side though.
Let me go check. I still see your screen.
Okay, let me stop.
let me.
I seem to be stuck on the screen.
share.
We're seeing yours, Vox.
Oh, you can see mine now. Thank
Yes,
you.
we can.
Let me go to presenter mode.
Yes, we
Thank you.
can see you.
Okay. Thank you so much, Dr. Nzimande, about those two cases, which are very difficult to treat, and showing us that cutaneous T-cell lymphomas, they don't do well. And it was clearly shown in these two cases. Is everyone hearing me?
Yes, we can hear you.
Okay, thank you. Today I'll be presenting on the topic confronting aggressive cutaneous T-cell lymphomas, and I'm Siyabonga Vokeka, as I've been introduced by Dr. Kujali. Thank you for that introduction. Let's keep going. Let me use this then. Okay, today's topic, the outline is classification of mature T-cell neoplasm, and we'll be looking at aggressive entities, mycosis, caesarea, the clinical presentation, diagnosis, staging and treatment, and also we look at the primary cutaneous CD8 positive aggressive epidermotropic cytotoxic T-cell lymphoma, and also we'll be looking at primary cutaneous gamma delta T-cell lymphoma. The mature T-cell lymphomas are actually classified according to whether they are cutaneous, and which is the most, which is our topic today, whether they are extranodal, going to other visceral organs in the body, and also nodal in the lymph nodes, whether they are leukemic. Coming to introduction, primary cutaneous lymphomas are second most common extranodal non-Hodgkin's lymphomas. They may be either T-cell, B-cell, or AK, NK cell origin. Mostly they are actually T-cell in origin, more than 80% of them. The cutaneous T-cell lymphomas are out of them. They comprise a group of heterogeneous lymphomas, which clinically differ from systemic lymphomas. They are the most common ones, and the most common one is actually mycosis fungoides, which occurs more than 60% of them. This is the classification, which is cutaneous, which is mycosis fungoides, caesarea. Caesarea has been moved actually to leukemic. I will explain that later. But it actually presents cutaneously. And the primary cutaneous CD4 positive small or medium T-cell lymphoproliferative disorders, primary cutaneous acral CD8 T-cell lymphoproliferative disorders, the primary cutaneous CD8 positive aggressive epidermotropic cytotoxic T-cell lymphomas, which we'll discuss, and the primary cutaneous CD30 T-cell lymphoproliferative disorders, subcutaneous paniculus-like T-cell lymphoma, primary cutaneous gamma delta T-cell lymphomas, which we'll discuss a little, and primary cutaneous peripheral T-cell lymphomas, not otherwise specified. And then we go to extranodal. The extranodal NK T-cell lymphomas, hepatosplenic T-cell lymphomas, indolent gastrointestinal tract lymphomas. We also have indolent NK cell lymphoproliferative disorders of the gastrointestinal tract, the enteropathy-associated T-cell lymphomas, and the monomorphic epitheliotropic intestinal T-cell lymphomas, and also the intestinal T-cell lymphomas not otherwise specified. The nodal ones, we have peripheral T-cell not otherwise specified. The anaplastic large cell lymphomas, they can be ALK positive or ALK negative. The breast implant associated anaplastic large cell lymphoma, EBV positive nodal T-cell, and NK lymphomas, and also the nodal ones, lymphoma which are in angioimmunoblastic, and the nodal ones which are follicular, and the follicular ones which are not otherwise specified. The leukemic ones, even though the other T-cell lymphoma leukemia is categorized here, it presents actually cutaneously. It has got different subtypes, but it is well placed as a leukemic, just because it's very aggressive actually. And we have the aggressive NK leukemia and pro-lymphocytic leukemia, T large granular lymphocytic leukemia, NK large granular lymphocytic leukemia. The aggressive types are MF and SS, and primary cutaneous CD8 aggressive epidermotropic cytotoxic T-cell lymphomas, the primary cutaneous gamma delta, and also the primary cutaneous T-cell lymphomas not otherwise specified. Now coming to mycosis and Caesar. These diseases have been considered as the same for many years, just because they share so many characteristics in terms of even the presentation cutaneously. However, the neoplastic cells of MF and SS, they have distinct immunophenotypes, which are quite different, which are, I'm gonna just talk about them. Both of them, they can express CCR4 and CLA, but the CCR4 chemoreceptor is more expressed in Caesar, of which the most important ones, the first ones which I should have been starting with, they are CD3 positives, CD4 positive, they both lack CD7. And in that lacking of CD7, the Caesar also lacks more of CD26 than the actual mycosis fungoides. And also, mycosis fungoides also lack CCR7 and L-selectin, which are lymph node homing receptors, and whereas the Caesar, they do express the CCR7 and L-selectin, and also the CD27. And as I said earlier, the CCR4 is actually more strongly expressed in Caesar. They also express PD1, which is CD79 in almost all cases. They also express killer cell markers, CD150K, 158K, which is KR3DL2 and NKP46. The KR3DL2 is actually one of the natural killer cell markers which the therapeutics are looking at. So in conclusion, these findings suggest that the MFA and SS are distinct diseases originating different subtypes of T lymphocytes, and WHO classification 5 has actually included under mature T cell and NK cell leukemias. Coming to epidemiology, MF accounts more than 60% of all cutaneous T cell lymphomas, whereas Caesarea accounts for less than 5%. They both are common in adults or over the age of 50 years. Basically, other texts, they say above 60 years. The male to female ratio is higher in males than in females. Coming to etiology, the mechanisms behind are really not known, but there are various hypotheses like genetic and epigenetic abnormalities, environmental and occupational exposure to solvents and chemicals, and T lymphotropic virus type 1 cytokines such as interleukin-2 and interleukin-4. The pathophysiology, non-specific pathogenesis has been identified in subtypes of mycosis fungoides. There are alterations in the tumor suppression pathways associated with T cell activation, where we see that in folliculotropic mycosis fungoides, there's a potential role of Th2 cytokines, and in granulomatous mycosis fungoides, there's a potential role of T1, T17 regulatory cells, and in hypopigmented and pediatric mycosis fungoides, there's T1 mediated response driven by CD8 positive phenotype. The manifestation of, I don't know what's good, of MF and SS, the Sézary syndrome mainly presents with erythroderma and generalized lymphadenopathy. Whereas when we look at mycosis fungoides, it presents early. There are different stages. There are early and advanced stages. In early stages, we appreciate the patchy and the plaques with slow growing lesions. And in advanced stages, these are progressed to nodules, tumors, erythroderma. The patches become erythematous and scaling. The tumors become eroded and with ulceration. Excuse me. The subtypes are the mycosis actually have got three distinct subtypes. The folliculotropic mycosis fungoides, the pagioid reticulosis, and granulomatous leg skin disease. The sites of presentation, the folliculotropic mycosis fungoides are presenting at the head and neck, the eyebrows, extremities, and also the abdomen. The pagioid reticulosis, they present on the distal extremities, hands, and sole and trunk. The granulomatous leg skin, intertriginous areas like axilla, inguinal region, and buttocks. The other variants or subtypes, we have the granulomatous mycosis fungoides, pediatrics mycosis fungoides, which is usually CD8 positive, syringotropic mycosis fungoides, and hypopigmented mycosis fungoides. These are the clinical presentations of our patients with actually mycosis fungoides with different stages. And we see the patch stage, which we're having, which is the earliest lesion, which is actually can be small or large, small ones being 2 to 6 centimeter in diameter, the large one more than 6 centimeters. And these are usually brownish, scaly patch, which may show slight atrophy in them. They are seen in the large ones. They are seen on the trunk, gluteal region, proximal extremities, and mammary region. The black stage, we see the lesions now, they appear larger, and the annular horse-shaped, and also with an infiltrated base, and also asymmetrical distribution, as we can see in this area. Coming to tumor stage, this one is quite a bad state of in the patient, where we see the tumor, the areas which are erythematous with papules, and also some of them, they actually discharge some sort of like oozing. Coming to evaluation of this patient, the patients actually, when we evaluate them, we have to have a complete physical examination. We have to follow the laboratory. We have to have skin biopsy, bone marrow aspiration trephine, and also radiological and lymph node biopsy. On the physical examination, this is very much important, more especially when we are going to do the staging. We have to know the type and extent of the skin lesion, the number, the size, and site of the lesions, estimated body surface area, as we're gonna be talking of this in the staging, and look for lymphadenopathy or acromegaly. The laboratory, we have to check the biochemistry, lactate dehydrogenase, and beta-2 microglobulin, which will help us to know that these patients, they are having, if they are high, there is a indication that they will be having a high tumor burden. And we go to full blood count and smear. We will be looking at the microscope, the cells like this, the cerebriform cells, which are abnormal lymphocyte Caesar cells, which we have to determine the absolute number of Caesar cells. And we're gonna go through that. The immunophenotype, they are actually, both of them, as I already explained, that they are CD2 positive and CD3, CD4 positive. Though in later stages, they might actually lose CD2, and they are having CD7, which is dimly expressed or negative. CD8 is negative. It's more in most of the cases. However, they are CD8 positive for mycosis fungoides. The CD30 might be actually positive or negative, but in large cell transformation, they usually present with CD30 positivity. And the CCR4 receptors, in most cases, is as positive, more especially in Sézary syndrome. The PD-1 usually expressed in most cases, both cases of MF and SS, but however, SS expresses more of PD-1. In advanced stages, we actually have loss of PEN-T cell markers, CD2, CD5. This is the Sézary syndrome diagnostic criteria, which we have in Sézary cells in the peripheral blood of more than 1,000 millimeters of to the third, but actually it's more than 1 millimeters per microliter if we are not using millimeter to the third, and immunophenotype of lymphocyte in peripheral blood. The CD4 positive CD4 8 ratio is more than 10. That is CD4, it must be greater than 10. CD4 positive, CD7 negative, it must be greater than or equal to 40%, and CD4 positive, CD26 negative is greater than 30%. There has to be a T-cell receptor gene rearrangement, which must be the same in the peripheral blood or and in the skin. Coming to the skin, this is very much important, the skin biopsy. It must be done on the most indurated area, which must be selected. Most of the patients, they actually done skin biopsies, but they are negative. If ever there is not carefully determined which area to be biopsied. And most of the patients, they will actually be treated for psoriasis for quite a long time without actually confirming the diagnosis. Coming to the lymph node biopsy, an incisional biopsy is performed from the largest draining lymph nodes as guided by the PET CT, and also the cervical lymph nodes are actually the preferred size, followed by axilla, and then the inguinal. This is a case where I actually picked up in one of the articles. This patient was actually known with mycosis fungoides, and developed to have a large cell transformation not responding to treatment, which we can see that these are the infiltration of the mononuclear cells on the dermis, and also on the dermis here, and then also now it's being actually mixed with larger typical cells. And on D, these large typical cells here, they are actually CD4 positive, and they are on E, they actually have low CD8 picking, and also now in D, they are strongly picking up the CD30. The summary of investigations is in this table, which I've discussed most of the things, where we do the complete physical examination, and then we determine the site where we actually have to do the skin biopsy, and then we do the blood test, and then we do the TCR gene arrangement and do flow cytometry, and also we do the radiological tests, CT scans, and also chest X-ray, abdominal ultrasounds, and also CT staging, and then we do lymph node biopsies. And also, which is not in this table, we have to do the NGS to check the genetic mutation, more especially the TP53 and CDKN2A or B, which these mutations are actually associated with poor prognosis. Staging systems, we are looking at the International Society for Cutaneous Lymphomas, and also European Organization for Research and Treatment of Cancer. And we are having the modified TNBM, of which T stands for skin, and N the lymph nodes, and the visceral part of it, and also the B for actually the blood. The staging system is quite you have to actually follow the table to actually stage this the patient. We have to do the flow cytometry. We have to do peripheral smears, and we have to know the absolute Caesar results, and we have to know the skin, how much the total surface area, which is the patient presenting, and we have to check the lymph nodes, whether the patient is having a lymph nodes or not, whether there is visceral involvement or not visceral involvement. Once we actually have those in place, and then we stage the disease. Diseases are actually staged into stage 1 to 1A to 2A, which are early stages of the disease. And we go to stage 2B and also to 4, which are actually advanced stages of the disease. So in order for us to appreciate, we have to actually go on and actually make a note of what we have found on the patient and put it into the clinical context, and we clinical stage the disease. The differential diagnosis, we have skin disorders which can be presenting like atopic dermatitis, contact dermatitis, dark drug eruptions, erythrodermic psoriasis. Of all these, these are skin disorders might actually resemble mycosis or MF. And we have also psoriasis, which is most of the patients, they actually diagnosed with psoriasis, and they actually end up being delayed of actually getting the diagnosis of mycosis or any other cutaneous T-cell lymphoma, or because of the fact that maybe it is difficult, of course, to actually get the right area where we actually have to confirm the diagnosis of cutaneous T-cell lymphomas. Coming to primary cutaneous CD8 aggressive epidermotropic cytotoxic T-cell lymphomas, these are quite rare. They present with disseminated eruptive lesions with central laceration and necrosis. The immunophenotype, they actually have CD3, CD4 negative, of which most of ML and SS, they actually present with CD4. These ones are actually CD8 positive and beta F1 positive, granzyme B positive, preference mostly positive, and TAI positive. They usually lack T-cell markers and also CD30. The differentials will be those of CD8 positive mycosis and also lymphomatoid papulosis type D. Coming to our second case, the primary cutaneous gamma delta T-cell lymphoma is quite rare as well, and presents with generalized patches, as we have seen on the patient that Dr. Nzimande actually presented. They have plaques and also deep dermal or subcutaneous tissues. The hallmark of it is the fact that they do have the TCR gene arrangement of that of gamma delta. They usually CD4 negative, CD8 negative, beta F1, multiple cytotoxic proteins, and also they can actually, some of them, they can be CD4 positive, as in our case. They do have variable expression of CD5 and CD7. Coming to management of the patients, now it becomes actually we have to be counseling the patients, more especially the patients with tumor stage. Some of them, they become like very ill. There are some of them, they become suicidal, and we have to counsel them, and we have to tell them the management strategies and also the options which are available, and also counsel the fact that the patients are not doing well. But however, once given chemotherapy, those are tumors, they shrink and they actually respond. And we have to make sure that the patients understand the aggressiveness of the disease and explain thoroughly. And also we have to actually ask like the family history, siblings, if ever the patients are having in the management, we are thinking that they are fit for transplant, which is quite a debatable topic, and we have to give them supportive therapy. Coming to early stage disease, which is stage 1A to 2A, most of the patients with stage 1A, they actually they are observed, some of them. You do not have to actually give them any treatment. And then 2A, we have to start giving them topical steroids and also retinoids, the bexarotene. And then we have to give them phototherapy, which is actually Zoran ultraviolet A, and also localized radiotherapy. And then if ever they are not actually doing well, and we have to go to second line therapy with radiation therapy like skin electron beam radiation, and also interferon alpha and methotrexate. And when we are starting with methotrexate, we start with the lower doses of less than 15 milligrams weekly, and then we increase to more than 15 milligrams weekly. And then coming to advanced stages of the disease, we talk of the first line, which is the same as the early stage. And if ever the patients are having the patches and also the areas where there are patches and also the blocks. And once we actually see that the patients are having more larger areas of our disease, we have to give a systemic chemotherapy where we use a histone deacetylase inhibitors, gemcitabine, liposomal doxorubicin, and then we actually have to give the second line therapy, which we'll discuss, like the monoclonal antibodies, checkpoint inhibitors. The advanced stage are 2B to 4. As I mentioned earlier, we have to have goals which we are having to explain to the patient that the diseases are actually aggressive. We have to aim to have a long-term disease control, treat and relieve the symptoms, and manage life-threatening aggressive disease. The newer systemic agents, we just made this table for the talk, which we having the monoclonal antibodies, which is CD30 positive, ones we give the brentuximab vedotin, which is anti-CD30. The anti-CD52, we give the alemtuzumab. The anti-CCR4, we give mogamulizumab, and the KR3DL2, which are natural killer cells. And then we actually give Tamab. And then we go for checkpoint inhibitors. We give the patients pembrolizumab and nivolumab, and the newer drug now, which is cisplatinumab, the JAK2 inhibitors, the ruxolitinib. The brentuximab vedotin has been approved in the use of relapsed refractory mycosis Sézary syndrome based on the randomized trial, phase 3 cancer trial, of which the patients were receiving BV and choice of methotrexate or retinoids, the bexarotene, and a greater proportion of these patients receiving BV achieved the primary endpoint objective global response lasting for at least 4 months, and which meant that this was higher than the other systemic agents which were compared with. The mogamulizumab, which is
Linda.
which is
Did you sign my
sorry, mute your the mogamulizumab, which is a monoclonal antibody against CCR receptor 4, on the phase 3 Maverick trial comparing mogamulizumab versus vorinostat. It was well tolerated, and it was considered to be used early in those patients with leukemic burden. The toxicity include mogamulizumab associated rash, which can be confusing with the rash that the patients are having. So those are patients with developed rash from mogamulizumab. The experience of treating a doctor is very much important. Coming to Tamab, which is an monoclonal antibody targeting killer cell immunoglobulin like receptor KR3DL2, which is highly expressed in actually in Sézary, and is one of the drugs which are actually having a potential to actually be used in actually as I mentioned, therapeutic, as it has been seen in the previous slides, that the KR3DL2 is highly expressed in Sézary. Actually, and also pembrolizumab, which is actually checkpoint inhibitors, in phase 2 trial of pembrolizumab in 24 patients. This actually the objective response rate was higher, and it was around 38%. But these patients actually didn't do well. They didn't actually have overall survival of 5 years. That's why it is recommended that once these patients are actually achieving any kind of CR, we have to actually cancel if they are fit for actually doing transplant. And the another one is, which is highly on the being studied, is tislelizumab, which is anti-PD-1, has an efficacy on this area, but it's not well studied very well, and currently is not available in the United States for cutaneous T-cell lymphoma. Now coming to strategies to improve depth and durability responses. Where it is recommended that patients with generalized tumors, total skin electron beam therapy with systemic therapies are accepted options. The total skin electron beam therapy can be actually used together with systemic therapy to actually prolong the response duration. Combining total skin electron beam therapy with systemic therapy, it has been proven in trials, but the trials are still continuing with actually mogamulizumab with the trial of trial NCT 04128072 and 04256 018, which is choose actually to clear the leukemic disease sitting the skin. Coming to management with the allogenic transplant, the approach is actually weighing the age and fitness of the patient and availability of donors and patient preferences, and also weighing the alternative options, like as we said, combining the actually systemic therapies as well. And also going to actually newer therapies as well. For aggressive cutaneous T-cell lymphomas, allotransplant remains a critical modality for certain patients, those who are fit, who are actually having donors, and also who can be deemed to be able to stand allogenic stem cell transplant. Incorporating radiation is an important strategy when using allotransplant as high effective modality to maximize pre-transplant disease control. Now it is this table is actually summarizing of what I just said in a flow chart. Stage A, we observe those with B, we can actually, stage 2A, or else those with stage 1A with some sort of skin being having manifestations. We can actually use skin-directed therapies, and these are the approaches like we use the localized radiation phototherapy, and then topical steroids and nitrogen mustard, and topical retinoids, the bexarotene, and coming to the advanced stages like 1B, advanced in the early stages, 1B to 2A, we use the skin-directed therapies, and which is if ever the patient is having a low level of involvement, that's, as we said, the patients can present with the patch, the plaque and tumors, and with the patch stage, we actually go via this route. And also if ever there is more involvement, we use the Soran ultraviolet A and topical steroids and nitrogen mustard. And if ever the area is too big, we use this total electron beam therapy. And if ever the patients, they don't respond well, we can actually go on and actually use systemic therapy as well, using the novel therapies, the brentuximab vedotin, interferon A, methotrexate, mogamulizumab, and also the vorinostat. And these are actually useful in this situation. Coming to the advanced stages, where we can actually in mycosis fungoides, when the patient is in stage 2B, we use monotherapy following plus or minus skin-directed therapy, the retinoids, interferon alpha, low-dose methotrexate. Stage 3, we use the monotherapy or combination of the following skin-directed therapies. And stage 4, we can use gemcitabine, liposomal doxorubicin. We can use BV as well. And then in SS, in actually first-line treatment, we use the interferon, retinoid, and prednisone, plus or minus chlorambucil. In advanced stages, and also with the second-line treatment, patients who are not responding, we can actually, in stage 2B, we follow gemcitabine, liposomal doxorubicin, BV, combination chemotherapy, and then if ever they respond and they are fit for allotransplant, we allotransplant them. And then if ever the patients are not responding well to first line treatment, we can use the total skin electro beam therapy and also BV in stage 3. And stage 4, we can use combination chemotherapy followed by allotransplant. And then in caesary, we can use a combination of we can use gemcitabine, liposomal doxorubicin, combination chemotherapy, mogamulizumab, and BV, and low-dose alemtuzumab, followed by allotransplant. I thought this was very useful in terms of approaching this patient. Coming to the prognosis of the patients, these patients are actually not doing well, and we have to make sure that even in our counseling session, we actually tell them that the prognosis is not too good, and we have to follow the staging as a prognostic factor. And these are the things which can be associated with poor prognosis: the presence of a cutaneous disease, stage 4, old age, greater than 60, presence of large cell transformation, as I showed the picture before, whereby the patients are actually transformed to CD30 positivity, increased LDH, folliculotropic mycosis fungoides is actually associated with poor prognosis, and the tumor distribution at diagnosis. Coming to the treatment for primary cutaneous CD8 aggressive epidermotropic cytotoxic T-cell lymphomas, these ones are actually not having the one-sided kind of like regimens. We can use other regimens which are used in treating other lymphomas like EPOC, and we can use gemcitabine with liposomal doxorubicin, followed by the allogenic stem cell transplant if the patients achieve complete remission and are fit for transplant. The total skin electron beam therapy for conditioning, and those which are actually having the JAK2 in their pathways mutations, that we can give actually ruxolitinib. The strategies which are followed even in the primary cutaneous gamma delta T-cell lymphomas other lymphomas, like we use chemotherapy like ICE, which is isofosfamide, carboplastine, and etoposide, and we actually follow the allogenic stem cell transplant once they achieve. And then there is these pathways which are of interest in primary cutaneous gamma delta T cell lymphomas, of which these are highly part of the pathogenesis of primary cutaneous gamma delta, of which these findings are actually having some sort of therapeutic implications, which will actually we'll see them in the future. Coming to conclusion, the patients with advanced stage cutaneous T-cell lymphomas often endure a chronic disease course. Frequent relapses are common, necessitating sequential systemic therapies. Over the past decades, several new agents have emerged, like new therapies which we discussed today, offering improved outcomes. However, the durability of most therapies remain relatively short-lived. Despite therapeutic advances, this condition remains challenging to treat and manage effectively. These are my references. Thank you so much to Dr. Kukuchali for overseeing my talk, and also the Albert hematology team led by Dr. Parasnath, and also colleagues like my consultants, Dr. Farah, and also Dr. Ramia, who is actually a fellow in clinical hematology, and to all the medical officers. Thank you so much, and also I would like to thank you, the Blood SA, for allowing and giving me the opportunity to present. Thank you. Over to you, Guga.
Thank you, Vox. Sorry, colleagues, my laptop seems to have gremlins, so I'll just connect with the speaker on my phone. Thank you so much, Andile and Vox, for that presentation. It was quite insightful and quite detailed. I'm not seeing any comments on the chat. Let me just open up my chat box. Okay, we've got a comment from Lindo who says, great presentation, UKZN team. May I ask the team and the community at large, in the absence of T-cell targeted therapies, what regimen is everyone using outside of methotrexate? And is the gemcitabine given as a single agent or combined therapies?
Gugu, can I answer?
Yes, please
what
go
we're
ahead.
doing? I think, see, the challenge here lies is that we often see these patients in the stages that the cases that we presented. But remember, a large proportion of patients will be seen by dermatology without a hematologist. And it's only when they advance that they are actually sent over to us. So, you know, with the second case, we're very limited with the male patient, and in discussion with the dermatologist, we decided to give gemcitabine and isotretinoin because that was the only real medication that was available both to us as hematology and to the dermatologist, and then obviously the radiotherapy. With regards to the first case, because she had all those tumor-like lesions, we decided to go with a chemotherapy regimen like GDP. But, you know, with all of that being said, we are really, really limited. And yeah, so it's not like we have a whole a lot of choices with these patients. And unfortunately, I mean, my experience is that they've all done so badly, and none of them actually ever got to a stage where we could transplant them. And as Vox said, and we don't see a lot of these cases in this stage. And yeah, so I must say my experience as well is really, really limited. I've seen in my lifetime here in this unit about maybe 5 or 6 over the past 20 years that actually got referred to Albert Luthuli. I think some of them might be seen at your unit, Google. I'm not certain whether the derm team refers to you, any patients that might be in earlier stages, but the type of patients we get at Albert Luthuli really are unsalvageable. It's just really, really sad to see what these patients go through, because it's a prolonged suffering. Like you can see both these cases, it was almost 10 years, a decade of suffering before they actually die. And I think, as Vox alluded to, the fact that psychologically it has such a huge impact, because they fear going into public. When they come to the clinic, their wounds are septic and smelly, and nobody wants to be around them. So it really is one of the worst diseases to actually treat. So I think that's all I can say, is that we often manage them in conjunction with the dermatologist, because they get large stocks of actually topicals to put onto these lesions, because it's so extensive.
Thanks, Charlene. We also get a few patients referred to us at VMH, and most of the time they are managed by the dermatologist primarily. And I think when then the lesions are not getting better, then they are referred to hematologies for chemotherapy. We do have another comment in the chat box from Moses. It says, thanks, Vox. I have a patient that I'm managing who developed MF at the age of 32 years, managed with topical and phototherapy by the dermatologist. 6 years later, which was February this year, I diagnosed her with a ALL with BCR-ABL1. Any link and any role for screening for germline mutations? Did you come across any link, Vox, in your reading with regards to screening or germline mutations?
I didn't come across. One of the areas which I think it was highlighted is the fact that the NGS has to be done at presentation, which was something which was previously not looked after. And one of the things which alluded to that was the fact that we can pick up genetic mutation like TP53 and CDKN to A or B mutations, but I didn't come up with the germline mutation in my reading.
Thank you, Vox. Sorry.
As well, Google, I will also, as I said, I don't have a lot of experience, but maybe these might be 2 separate diseases, but perhaps somebody else in the audience might have more experience. But I don't know if there is any sort of germline link to this.
Thanks, Charlene. We've got another question from Daniel. How do you manage alpha beta paniculitis T-cell cutaneous lymphoma? Do you follow the same principle of management as discussed? I personally have not come across a patient with this diagnosis yet. So I can put it out to the audience if somebody has managed this condition and how they approached the management.
No, Google, I haven't seen one in my lifetime, actually. So maybe somebody else in the country may have seen one.
Okay. Okay. I'm not sure if I missed any other comments. There's one from Jasmine saying great presentation. Okay, some coming now. From Lindo, she says there is one in her unit, which is in Baragwana. We initially started with steroids, and then the patient defaulted, and has now been started on CVP. And we've got another comment from Dr. Cecile de Toit, saying in nearly 30 years at Grooteskier, no patient with these lymphomas ever responded well enough to be transplanted. And I think Lindo had a follow-up to her patient that now the patient has since improved her condition. So I think with most of these conditions, they are quite aggressive conditions and seem very difficult to treat. And also, especially as mentioned here, patients are present late to hematology, and also then patients do default based on social circumstances, not wanting to be in public. Also, I think for them, their self-esteem when they have to travel and come to our clinics with the lesions that they have, and also the infections that their lesions present to them. So it is seeming to be a difficult condition for us to manage. But I think with research and more trials, possibly, we will get on top of this disease and be able to manage these patients quite early on and possibly improve their outcomes. I'm not seeing comments on the chat. If anybody has any last words or any other comments to make, you can unmute and speak. If not, thank you so much for joining this evening. And thank you for everyone who participated in the Q&A session. Thank you so much for the presenters, Andile and Vox, for the work put in and also for the presentations themselves. It was quite informative. And I think we can end today's session and we will meet again next week for our next session. Thank you.
Thank you.